Welcome, everyone, to today's episode on Fit as a Fiddle. I have a fellow physical therapist joining us on the show today. Her name is Dr. Diana Mayants. She is a dual board certified orthopedic manual physical therapist. She has over 13 years of experience in this field, and she also has various accreditations that she's going to go into a lot more. One of which I'll just describe is the Orthopedic Clinical Specialist, or the OCS, which takes quite a bit of time to complete, along with other accreditations that also are very time intensive and really get you the best clinical skills to show up for our patients in the best ways. So I'm really excited to have Diana here today. We are going to be talking about a lot of things around the physical therapy field. And the way we actually connected was we were at a course together, talking about muscles and spine and lots of really cool things. And we were really in a room full of like very, very different kinds of professionals within healthcare and adjacent to healthcare. And it was just really, really cool sitting next to her and just hearing all of these amazing speakers. And she was one of the speakers as well. We loved her talk and how she incorporated the physical therapy piece into spine care and really physical care in general, and how we approach patients in ways that maybe other fields don't. And of course, we're both biased because we're like, what we do is amazing. So we're going to dive into that a little bit more today. But we want to just extend a hearty welcome to Diana today onto the show. So thanks for being here.
Thank you so much for having me. When I found out that you had a podcast, I said, okay, sign me up. Let's do it. Yes, so I do have an OCS degree. So for those who might not be familiar, it's this 6-hour exam that you study for, and it asks you about all sorts of patients, all sorts of conditions, from TMJ, upper cervical, down to your toes. And in this 6-hour exam, you're introduced to 200 patients. And I mean, just the sitting endurance, after you've been in PT school for so long and then you're out practicing, you're on your feet all day. And then just to even sit for 6 hours, I think is a huge accomplishment. But yes, so I took that exam, and it really kind of opens your eyes to the best available evidence and keeps you up to date. It kind of forces you to look at those articles again, and again, just look at the best available evidence. The NAIOMT, the Certified Manual Physical Therapy degree, that's something that I did maybe 5 years out. I was working at a clinic where a lot of the therapists had their COMT or CMPT, Certified Orthopedic Manual Therapist, or Certified Manual Physical Therapist. And so, we did it through the NAIOMT program, which is very popular because it incorporates a lot of different clinicians' outlooks and not just, one kind of method, like a Cyriax method or like a Maitland method. It really kind of gives you a broad overview of different manual therapists. So I decided to do it in a year and a half. They said, okay, give yourself 3 years. I said, okay, yeah, no. So instead of waiting for the courses to be offered on the East Coast, I decided, why don't I make a vacation out of this? And I'll just travel to all these different states and take these exams and go to these courses and meet these amazing clinicians that I've heard so much about. So I'd go to Utah, and I went to Nashville, and you add like a few days on after the courses just to eat some barbecue or, hike the mountains. So it was really interesting. It was very intense. I will say that a year and a half is probably rushing it. But I'm really glad I did it because I couldn't wait to use the tools and incorporate. And, obviously taking a test, going to a course, listening to a lecture, that's really nice. And it's nice to have the initials after your name. But what really counts is you perfecting your craft in the office, doing it every day, going back to the books, reassessing, teaching patients, teaching maybe your students, and really kind of fine-tuning your approach. So again, I was very excited to use the fancy initials, but at the end of the day, I still had a lot to learn, and I still had to, keep the books nearby and keep things open. I would have patients that would come to me for one diagnosis, and I would say, "Do you have 5 more minutes? I want to try this new technique out on you, on your wrist." I said, "Well, I'm here for my knee, right?" It's like, "Yeah, this is a freebie." So so that's how it happened. And after I took the NAIOMT class, I said, "Okay, what's next?" And my husband said, "Why don't you just take a break? You've traveled to 7 different states in the last year and a half. Just take it easy."
Nice. Well, we are definitely, any physical therapist listening is like on board with the whole taking a course and then having to go back to apply it, because I think too many times what we do is we take all this information in and it's a lot, right? Especially if it's those weekend courses that are like 2 days, 8 hour long kind of lectures with lab, and there's so much information, and then you come back from it and you're like, what just happened? So I can only imagine doing that for a year and a half. And, I guess it's all about the process. It's about like, it doesn't happen overnight, but you just go back and you go back and you take what makes most sense for you and for your practice and the way you treat. Maybe not every single thing works for you, but a lot of it will. And you might have to just think about it in different ways to incorporate it in your brain in a different way than the instructor maybe taught you. But that also comes with time, because you'd have to have seen enough patients and done that method or technique or evaluation tool or whatever it is enough times that it kind of starts to become more a part of your repertoire, right? And then it just,
Sure.
that's how you evolve as a clinician. And I think it's always easier when you're right out of school, because you're so used to having to integrate that stuff. But then once you've been practicing for, you said like you were 5 years out or whatever the case was, it does take a little bit more, I guess, intentional effort to think about that stuff and make it part of your practice.
Absolutely.
What are some of like the biggest changes that you've felt you've made, and less so like the technical stuff, but more so just from like a holistic clinician sense? What are some of the biggest changes you feel like you've made before you've had those certifications versus now?
Sure. Well, confidence definitely was a huge help, right? As a new grad, you know so much, but at the same time, the more you practice, you realize how much more there is that you really need to brush up on, and how much more there is that you can, improve. So just having the data, even something as simple as, hey, 50% of patients who have a medial meniscus tear, like yourself, are in this situation 5 years out. And here's an article, here's some literature, right? So that was the OCS piece of it. The NAIOMT piece of it, I would say, is having a patient come to your office. And like many of us do, we do a proper head to toe assessment, take a proper history. But when you have them do extra movements and you point out these random joints that they didn't even know existed, or show them how things interplay, right? So you have a patient with a lower back problem, and before you even look at their back, you're watching them walk, you're looking to see what their ankles look like, you are assessing their hip mobility, you're looking at their, upper shoulder girdle. And so explaining to the patient how everything comes into play and how everything ties together, and the motion between all these teeny tiny joints, I think gives them a great sense of, of relief, and puts a lot of trust in the clinician, which ultimately gives you the buy-in, right? They believe in you, they believe in the therapy, they believe in the profession, and there goes your compliance and their, consistency. And that's where you see the results, right? You have these patients coming back and being part of the process and sticking to it. And I found that that was really rewarding when a patient comes to you and they say, wow, no one's ever asked me that, or wow, no one's ever looked at that, or wow, no one's ever explained why this is important and how this, comes together. So that for me was definitely the that aha moment.
And something that just comes to mind when you just said that, I had a patient recently who has like quite a significant amount of like cervical and thoracic involvement. And a lot of it happens with walking. And she's like, I've been to a bunch of PTs and I've been to like a chiropractor. I've done this, I've done that. And she's like, I just feel like as many massages as I get, or as many things as happens to me, I feel like this isn't really getting corrected. And so I was like, okay, so we're gonna take your shoes off. And then I had her in like these shorts, and then I was like, I lifted up the back of her shirt, and then I took a look at just like her back and everything. And I was like, And then I laid her on the bed on the plinth, and then I did a leg length discrepancy test. And I was like, did you know that you have like a full inch of a real like anatomical leg length discrepancy? It's
Wow,
not functional. It's like
never knew.
it's an inch. And so a lot of her, like, she was like, when I sit, I feel like I go like this and I go like this. And when I stand, I
Right.
feel like I'm shifted this way. And I'm like, okay, well, they screened you for scoliosis, and maybe that was clear, but they never looked at her legs, like no one ever
Sure.
took a look at that. And so that just speaks to, and that's not me like patting my head, patting my own back or anything like that. But it's just taking, and sometimes we miss it, right? Like somebody comes in for a very specific body part. Sometimes we don't just like zoom out and take a look at everything and how everything is moving as much as maybe we always should, especially if we're in a rush. So it just kind of reinforces how important it is. Like you may not get to every single evaluation measure that you feel like you need to and want to do, but at least over the first like 2 to 3 sessions with a patient, try to
Yeah.
get to most of them or all of them, because you might just be like, if you gloss over it and you're like, oh, okay, yeah, I just didn't get a chance to get through that hip thing that I thought might be necessary, even though they're coming in for like a right shoulder, and I'll just like skip it. You might be missing such a big piece. And those
Absolutely.
missing, and that's what we do. We put pieces together. We take all these missing pieces, we take this information, we put this investigator hat on, right? And then
Yeah.
we try to solve a problem.
Absolutely. We see it every single day. And, when a patient comes in, I'll listen to their history and they'll tell me about other treatments they've had, whether something worked, obviously make a note of that. Okay, if it works, let's keep it on the menu. Things that didn't work. And it's important to listen to the patient. That way you can kind of, be ahead of the game and say, okay, well, let's start with what works. And, let's not do what didn't work. But at the same time, you also want to do your own assessment and you want to look at this patient with a fresh set of eyes and realize that, maybe things weren't connected properly, or maybe things weren't assessed properly, or maybe somebody in the very beginning said, okay, well, you have X, and everybody just went off of that. And, nobody went back to the drawing board and said, wait a second, let's get a fresh picture here, you know. So
Mhm.
I definitely, to your point, understand, just taking a step back and doing a full screen.
Yeah. Diving into, once we have that full screen done, and once we may be offering other solutions for patients who may not have been offered those solutions before, or been described their reasons or the process for recovery for that particular pain point. How do you feel like you've gone about doing that when they've had this history that's been very long, and you're offering them something new that they may be skeptical about or maybe not be on board about initially?
Sure. Well, usually by the time some patients have come to see me, we'll call it a quote unquote complicated case where it's not straightforward, and, the gold standard of the treatment of choice has failed them and they've gone to different practitioners. And, these patients, after you've seen 3 or 4 therapists or orthopedics, things get a little muffled, right? And patients get exhausted. So usually when patients come in, they're a little bit excited almost to try something new or to hear something new or to say, well, maybe it was my label diagnosis that kind of steered me and offered me the wrong treatments. Maybe it's the diagnosis, maybe it's not the treatment. And in those cases, I feel like it gives them a sense of hope and a sense of, again, relief to know that, I'm not out of options here. Maybe we were just looking in the wrong cabinet, so to speak.
Yeah. And then most of the time when that's happened, I'm sure to you as well, you shift gears, and then it's like, okay, we have to take a look at this in a different way, and you kind of have to re-educate them on what the plan is and what's happening. And I feel like that education piece can be so helpful in that moment, when they have been told such different things before. And then sometimes I felt like sometimes there may be some resistance to doing things. They're like, well, I always did this thing this way, even if it's just as simple as an exercise, for example. And then you can explain to them like, well, this is the purpose of doing this slightly differently and why we're doing it this way. And usually that's all it takes for them to be like, oh, okay. And when they see the results, it kind of just fits in with like naturally, right? They're going to keep doing it. They see the results and they're going to keep following with the home exercise plan or whatever, functional training or the new ways to move their body. And sometimes it can be such an aha moment, right? Have you had some of those with people where they're just like, they come to you and you explain something to them, they come back the next session and they're like, whoa, that's
Sure, I
crazy.
absolutely. I mean, we see it all day long, right? That's kind of why we're in this profession. It's really rewarding to be the ones to find something, shine the light, and have the patient say, "Whoa!" I mean, it's really really great. Sure, I had a patient with a chronic lower back problem. She got injured during COVID, as a lot of us were cleaning our own homes and using poor body mechanics. She suffered a moderate to severe injury, which later resulted in her having a robotic surgery with hardware placement. And so she became this chronic lower back pain patient with radiculopathy and all sorts of other kind of sympathetic symptoms. And so she wanted to come in and describe her history and the amount of times that she said, my right leg, my right leg, my right leg. And I said, let's not call it your right leg. Let's give it a different name. Let's not talk about your back. I want to work on something else. And we worked on everything around. And I think the number one thing that we had to do was break this pain cycle. And like I mentioned in my talk, stop stimulating the area of the brain that interprets the right leg pain, the back pain. Just stop watering that flower, right? Shift the gear. How many times have you had a patient tell you that they didn't have pain over the weekend and you thought, great, Friday's treatment worked wonders? And then they tell you that they had this amazing weekend where they went to see a show and they saw their grandkids and they went to this restaurant and their gear was shifted, right? So I think that's a very, and look, I'm not dismissing physical therapy and, treating the laundry list of impairments, but I think that there's definitely an oversight. And this happens a lot in very busy clinics, right? Because we can't put that kind of time into just the brain portion of it, right? That doesn't always allow. So I think just having the patient shift gears and focus on other parts of their bodies, and again, realize how things work together, right? So in her case, we needed to strengthen her left leg a little bit more. We needed to get that leg stronger so she can start using it a little bit more. We wanted to take the emphasis away from the right leg, and we wanted her to stop talking about this, constant pain that whether it was going to get better or worse, we're not sure. Her prognosis was a little bit, poorer than in a more acute case. Maybe a younger patient, maybe somebody that didn't have surgery and didn't have all these failed treatments. But at the same time, I think it was important to treat her in a holistic manner. And we did see a huge improvement. She did feel better. She, shifted her gear again and got stronger and was able to be much more functional.
Yes, I love that. I'm gonna chime in with the example. This is like almost like 6 or 7 years ago, and this patient still so like salient in my memory. She was coming to me. She had endometriosis, and she had quite a significant amount of like pelvic pain and abdominal pain, and we're working through a lot of different impairments. And whenever we would try to incorporate a new exercise, whether it was something like supported standing marches, like hip flexion in place, or if it was something as simple as like squatting mechanics to be able to pick down and pick up a squat down and pick up a dumbbell, something simple that's functional. This stuff would create significant amount of pain and true pain, because everyone's experience of pain, as we know with pain science, is real, very real. And it's the way that they're processing that pain. And that's very subjective from person to person. And we can never, ever dismiss that. And then I remember I was like, okay, so what can we do to try to get you moving a little bit more? What can I do to help you? Right. And she was like, I was like, what are the things that you like? Like, do you like a particular smell? I was trying to use like more sensory kind of things. She's like, I really like listening to music. I was like, okay, great. Who's your favorite singer? Or who's your favorite band? Or who's your favorite artist? So I took her to the PT gym and I changed the music for her. And I put that particular music, and, I was like, why don't we just like slowly start moving our body? And eventually she was marching in place, and eventually she was squatting down and picking things up, and she was moving. And it just shows and for many people that might not be the case, right? Like they physically cannot do that movement for XYZ. But when we think of chronic pain, and when we think of, just like the will to reframe, kind of like what you were saying, like stop watering that plant of this hurts, so I can't do this particular hip flexion, lumbar flexion, whatever it is. But then we shift gears to like, let's do this fun dance move that kind of takes out the anatomical, structural part to all of it, and just incorporate something more human and fun and light. It really can shift something in the brain for people. And I'm sure you've seen this time and time again, where like you see somebody who's sitting in the waiting room, and then they might bend down and pick up their handbag with like a full water bottle in it, and then come into your office room, and then we might ask them to do like a seated lumbar flexion, and it's like immediate pain, right? And so the mechanics of those two things are very similar. So you would think if you can't do one, you should not be able to do the other, and vice versa. If you can do one, you should be able to do the other. But when you put things into context, that's why the context of a movement is really important. And as movement specialists, we have to understand that, right? And we have to help our patients, not trick them to doing a movement. That's not what I'm saying. But just, are there ways that we can maximize your movement capacity? Because that is really what we do, even if it's still positions and postural things. And that, I think, is still movement as well. And so as clinicians who are experts in movement and optimizing movement, there are so many ways to think about it, to describe it to patients, to explain it, to change it, that we can really help them in different ways. And sometimes taking out the anatomy piece, as much as we want to like educate them on anatomy, sometimes taking that out can actually be really helpful. I don't know if you felt the same way, or if you want to chime in on that.
Sure, that's interesting. Yeah, I mean, I think to your point, a lot of patients are programmed to think, okay, when you ask me to bend forward, I've had pain doing that, and I'm anticipating pain, and the muscles are already kind of guarded, and the patient's already, they're holding their breath, they're nervous, they know they're getting assessed, versus, oh, hey, I dropped my pen. Can you just grab oh, here you go. You don't think about it. You just kind of do it, right? The motor planning process happens so quickly. Our brains do this, so fast that we don't really think about it. But when we're asked to be in this kind of closed, quiet environment where, again, we know we're being assessed and we're being analyzed, that's when patients get some performance anxiety. And I've had a patient who had very severe kinesiophobia. He was terrified to move because he's had all these injuries. And again, in a closed environment where he knows he's being watched, he was nervous to do it. But when you gave him a task, he didn't think twice. So we see it all the time, absolutely. And you have to be creative. When you're a physical therapist, sometimes you have to not trick your patients, but again, just be creative in the way that you describe a movement, instruct them in a movement. That's why I like to take the emphasis off of the area that hurts, right? It's not, okay, you're here for, jumper's knee. And so I'm going to have you push your knee down. Okay, you feel my hand here? Push down. Can you activate this muscle? Can you get a nice VMO contraction? Okay, that's great. So it's all about the words you use and the way you kind of instruct that I think makes a world of difference.
Absolutely. With all of the evidence and the research and everything that you've been looking into the last several years, is there something within our field in physical therapy, or maybe just particularly in your personal, professional growth that you're really most looking forward to? It could be really anything, but just something that you feel like in the future, in the next 10 years or 20 years, or however long, it's just something that we feel like will be helpful for our profession.
I do, as controversial as this topic is, I am excited for the advances that AI will incorporate into our field. I don't expect that it will be a George Jetson kind of, robot walking into the treatment room to see our patient, but instead, I think just having more systems, more checks and balances, an extra layer of advice or maybe a way to kind of decrease the errors that we might be making, right? Maybe you assess this patient and there's a laundry list of impairments and you never got to this one thing. Maybe the AI system will prompt you to look at something else that might be the missing link between the patient feeling 95% better or 100% better. So I think we'll see a lot of advancements in the future in the sense of just our systems and the way we analyze and assess and kind of collect our data. So in that sense, I think we'll see a lot of improvements.
Yeah, I love that you said that. I was thinking along the same lines as well. And I think one other piece that I think the AI or any kind of technology can offer our profession is a level of standardization that's appropriate, even though what we do is so personalized in patient care. And I think to your point, it's the reducing the errors that I think will be the most helpful, because every clinician is different, and that's really good too, as you get different perspectives and a different set of eyes. But I remember when the course that we were at together, that particular hospital was mentioning how they do have a very specific standardization in terms of how they treat spine care. If X, then Y, if Y, then Z. They kind of go through these checks and balances in some ways to make sure that the patient is receiving all of the care providers that they need. I'm sure that involves some level of, okay, well, if there's a questionnaire, some level of understanding of how much is this impacting this person's quality of life and their mental health, that's probably a really good referral to see some mental health specialist, or a psychologist or somebody, or a psychiatrist if needed to be. And I'm sure that there are ways to make sure people even get the right referrals. I'm super excited to see this in the pelvic floor world, especially somebody who treats pelvic health so much, because it's like they're way more in other fields of orthopedics, but I feel like it's the least when it comes to the pelvic floor and pelvic health. So I am really looking forward to, particularly in like the pregnancy and prenatal population, to see obstetricians and other clinicians that see particularly like the pregnant and postpartum population, to give them the right referrals. Because right now, even with major abdominal surgeries and C-sections, people are sent home with zero care, zero advice. Even with like the most simplest spine surgery that's been refined for decades, people go home with at least a set of things that they should be thinking about, and referrals to physical therapy, and definitely in bedside PT immediately post-op. So yeah, I'm really looking forward to AI in all of its glory and all of its benevolence to shed some much needed light into, physical therapy and patient care in ways that I really do think it's going to be very helpful. Of course, without taking the piece of clinician empathy and education, and there is that human element to anything in healthcare. You can have like two of the exact same doctors telling you almost exactly the same things, and I think two patients will come out of that taking away very different things if it was just described in ways that were different, or if the energy was different, or if the patient's mood was different. There's so much evidence that shows how communication and body language and those kinds of things have an impact. So I know that part is really important as well, but there's still a lot of things that could be standardized, that I feel like will only help.
Sure, absolutely.
Yeah. All right. So, Diana, is there anything else that you wanted to add to this conversation today? Anything you really want to share with the audience? And definitely along with that, where people can find you.
Sure. No, I think you did a great job, and I thank you for your time. And I'm really excited to follow you and follow your podcasts in the future. Patients or clinicians or anybody else can find me in my office in New Jersey. I'm in Livingston, New Jersey, or they can find my website, orthopro.nyc.com. Our practice used to be in New York City, then we opened up a second location. Now we're primarily in New Jersey. So thank you again for having me. And I had a lot of fun discussing these PT pearls with you.
I love it. Thank you so much, Diana, for your time and for being a part of our community. And hopefully we can do this again in another season.
Would be happy to. Thanks so much.